But for those of you who don't know me, I'm Ken, and today we get the opportunity to be able to practice some of the more difficult things that we as clinicians do, which is basically listening. I always think that if you can listen to me for about 30 minutes or so, you should be able to listen to your patient this time, with the purpose of, I guess, being able to find out and figure out and how to assess their pain from the information you gather from them. So the first post over here is basically a typical post you see when you see something like this, when you're scrolling through my phone or looking at Instagram or Facebook. And these are wonderfully motivating posts to see, of course, and it offers a ton of information when you see the pictures in here for the MRI, and also the picture you see of my daughter and I running, actually more of like walking and jog walking, a 5K about 8 months later. So the tough part is that in between here and here, everything looks so instant. You don't understand that this long journey, this arrow in the center represents all kinds of things that were skipped. So a lot of times people end up becoming surprised with how much time it takes for us to be able to physically recover. And from being able to, again, when that MRI was taken, to run that slow 5K, a lot of patients will tell me that, I don't have time for this. I got family to feed, I got work to go to, I've got parents to be able to look out and look into. I don't have time for this healing stuff to happen. And which is sort of unfortunate because time is necessary. In 2023, I don't know if anyone remembers here, but I had a miserable 2023. I had, thank you, Rocky, for witnessing that and comforting me during that time. And it was on the, I guess I had injured my back, I had radiating pain, I also had injured my knee. And that's what that meniscus you saw over there, that tear you saw in the meniscus on that MRI was about. So I was feeling really good after about a year's worth of rehab. And yes, it took me a year to bounce back and be able to just go slowly down a mountain and go snowboarding. We decided to celebrate with my son 2024 on New Year's Day. Everything went from really happy over here to all of a sudden really painful, really stressful and frustrated. There was a little bit of self-pity that came up, and even some depression, I think, that hit me when I felt like I ruined 2024, which was supposed to be the year everything was going much better. So today, my dream is we as clinicians are going to be really well versed at stories that we see our patients tell us sort of unfold here in the hospitals or the clinics, and sometimes even the nursing homes, if some people work over there. Advancements in our busy modern time right now had made everything so instant. Everyone can just purchase something with a credit card, pay for it later on with interest, of course. And everyone almost expects that when they come in that their healing should happen really quickly as well. So it becomes really important, I think, with this time frame, courtesy of the prehab guys, to be able to explain how long it takes bone to bounce back, which is, I tell them, about 90 days for muscle, about 6 months or so from an injury, and then tendons, 9, and ligaments, maybe a year or sometimes longer, and as well as the nerves, if there's some neural damage. It's really important that I go through something like this and their expectations are clear, that it takes that long to recover before I even make a SMART goal with them, because there's a time frame in there that is required to create our SMART goals. I believe in evolutionary growth is what I tell them. And evolutionary is kind of peaceful, kind of like watching plants grow, versus revolutionary. Anytime you hear the word revolutionary, there's like a revolutionary war or something changed so abruptly that it's upsetting and it makes it difficult for somebody to be able to adapt into. I tell them, okay, imagine going down the freeway, you've got these habits that you're trying to change, and all of a sudden, hey, I'm going to quit smoking. No one just quits cold turkey as easily, and there's a weaning process that has to happen. You don't slam onto the brakes if you're going 70 on the freeway, tires are smoking, you make a U-turn and then hit the gas and try to go the other direction. There's a good chance something will happen to where there's a rollover or a failure that will happen. So it's much easier to slowly exit the freeway if you're trying to change direction or a habit or a personality. Hit the brakes and then make a U-turn when the light turns green. hit the gas, and then you're going to be, speeding off to merge with traffic, and now you're going the opposite direction in a graded progressive manner. Same way we progress exercises. We don't overdo stuff for them. We start slowly and build them up. Now, I want to revisit that MR that you saw earlier, and then over here, this Baker cyst, and here's my small posterior horn looking tear in my meniscus. That was in 2023 that I eventually got to running for. So if somebody comes in with a story like this, and they've got their X-ray or MRI from 2 or 3 years ago, or you hear sometimes stories about, hey, it all started when I fell out of the back of my daddy's pickup truck 50 years ago, and ever since then, my knee's been bugging me the whole time. And I could kind of go on and have them go on, but I'd almost feel like you're almost lying if you didn't want to stop that patient right away and say that, hey, that's good and well, but that happened 50 years ago. You're talking about new stuff that happened, and you only told the physician maybe 6 months ago that this is bothering you. So that has nothing to do with it. That probably healed about 48 years ago is all. So this is where it becomes important to listen, because according to Lowe, the most important predictor of how to assess somebody's pain is the experience and the duration. This person might have had 48 to 50 years worth of experience in his pain. And that's where you get all the information from, not the MRI, not the X-rays, not any of this imaging, because that paints your picture more accurately. And it's also shown that a lot of the X-rays or MRIs don't necessarily give good information about if somebody's in pain or not. It just shows our anatomy. It catches red flags. It catches all kinds of things that require maybe surgery for that person to happen. Fortunately, I actually listened to a couple of people in here, and in my opinion, compared to what I was saying maybe 10, even 20 years ago, I see the new grads in here saying much more comforting things, more so than I did back then. So I mean, golf clap to that at least. So rather than the simple post you saw in the very beginning, where it showed the Instagram picture of me or my MRI, and then all of a sudden me running, this is what happened in 2024. Got happy, went snowboarding, crashed because trying to learn how to jump in the snow park. Sent my PCP the pictures to the VA and say, hey, can I come in? Because he's also an urgent care. And the nurse emails me back right away and says, hey, over here, can you just go to the ED? I think that's too much for us to handle. That looks pretty horrific. And I was thinking, okay, well, if they can't handle it, I go straight to the ED. And then when you get there, here's the other instructions. I give them a call. Make sure you call for wheelchair services to pick up your car and give your car off to valet parking, because I don't know if you can make it in here. And I'm thinking, wow, I made it back from the mountains. I should be able to make it back into the ED, at that time. So they actually did a really thorough job. The NP gave me a really good assessment, an evaluation. They gave me crutches, because they actually wanted me to go with the walker, but I said, well, Mom's got one, and I'm done working with that. So they gave me crutches, and then they took an X-ray, and I just had one last comment that the NP said, and said, yeah, go ahead and see the orthopedist. Let's make an appointment for you. We saw there's a bone fragment I think I saw in your X-ray. And I said, wait a minute, a bone fragment? Is it kind of serious to where is it floating? Because if it is, I'm more concerned about could it be like a sharp shard that could get into my healthy meniscus or my healthy cartilage? Can it shear it around if will it catch in there mechanically? And the only comment he could say was, I can't answer that question for you. Only the NP can. Only the orthopedist can. So for 6 weeks, I literally was losing sleep over this. I was like, oh, does I feel like my knee's stuck? Mechanically, is it shearing some stuff over there? And I didn't really want to bend it and push it too much. But fortunately, it started getting a little bit better. So at least I had that peace of mind in my head. So that experience over here that just taught me that what we tell our patients significantly can change their lives. It's where I was getting like 4 hours of sleep or 3 hours of sleep, sometimes waking up, thinking about these things. And Darlow et al. In 2013 over here has his quote, with healthcare professionals have a considerable and enduring influence upon the attitudes and beliefs of people with low back pain. It is important for this opportunity is used to be positively influence the attitudes and beliefs. So let's take a story we'll read this story. This is part 2. This was a game changer because when I did finally see the orthopedist, she took her evaluation up a notch. I explained everything. She looked through my records, and the one of the first things I said was, "Hey, it's not a floating bone fragment? Is that anything that could be shearing in there? There's not a shard in there that could damage anything else and make me worse in the future and accelerate my degeneration, right?" So the first thing she asked me was like, "Hey, what do you do? Why are you using this terminology?" I said, "Well, I'm a PT," and she said, "Okay." And I think the concern in my voice and the look in my face, she pulled out her ultrasound machine, and we just did a diagnostic ultrasound, and she just showed me, okay, here, it's an enthesopathy. And I was like, oh, okay. So it's basically a bony buildup for calcium that is in the knee that comes up from either a heavy impact to where more calcific deposits go into, but it's not floating. It's not anything dangerous. It's fixed, or multiple traumas. And my history, I think I was doing a lot of low crawls, under concertina wire sometimes, with sometimes bullets over my head at times. And I was doing a lot of knee strikes when I was competing for my school in Taekwondo before. And that explains everything, because I also had a heavy impact on my knee when I landed on the ice while snowboarding. All right, so I don't know if anyone could tell me which one hurts more out of the two pictures. Anyone? Left? Who's right? Who says left? All right, one. Who says right? Just another one, right? Now this is my right side. So it just shows over here where it's got the tissue a little bit more inflamed. Over here, it's a lot more distinct because there's not a lot of inflammatory fluid that's going on in that image as well. So my overactive imagination finally settled down from this orthopedist, and other than that, she had a really good smile, so maybe that also settled things down. And if your patient brings in an X-ray or an MRI, I was curious, what would you tell that patient? What if they have an MRI and shows, hey, here's some degeneration of my spine going on? And I sometimes would get this from the spine center. Well, I like using this chart over here. This graph by Lowe et al. In 2017 shows in this green line when they're taking MRIs or X-rays or doing body scans of people who are like even 18 years old sometimes in the Italian Air Force as cadets. They're investing that time to see if their anatomy of their body has any medical influences to not allow them to be a good investment in, to make them a full-fledged, like maybe airman or so. And it shows degeneration continuing to happen with every decade that we as people get older. So this blue line over here represents the intensity of the pain and the symptoms of what maybe their back is feeling. And over here, when it's like 40-ish years old, people are saying that they've got some of the most excruciating and intense pain during that time. And then a funny thing happens right around 55, 56, maybe 57 years old, where these lines sort of intersect, where as degeneration is worsening with every decade, people are starting to tell us, hey, I'm starting to feel better. Or wait a minute, my back pain is becoming less. So as a younger clinician, it would have been tougher for me to make an explanation of that. So other than I tell them, you know what, this is an MRI and it doesn't show very well how painful your spine is, how much suffering you've had, how many things you've gone through. It just shows a picture of your anatomy, and that's basically what it is. So we can't use a lot of these imaging for explaining why stuff is painful for you, but we can give you these handouts, and you can fill in these blanks about all the other stuff that truly paints a picture that is much better for us to determine how to make your treatments and how to create your treatment plan. So as far as a pro tip goes, I had another patient tell me that you didn't even do an X-ray, the physician didn't do an MRI. How are you going to give me a treatment when you have no idea what's happening with my spine at all? You've never done an X-ray and MRI. I say, you know what? A lot of us have gone through even doctoral programs, and what we do is we know the Canadian C-spine rules, the Ottawa ankle knee rules, all those things, and we know all the things and symptoms you'd say, and we can detect if there's a red flag there. These X-rays and these MRIs are really good at detecting for emergencies. And if we catch an emergency anytime during this eval, I will definitely send you off to the physician to get all that needed imaging, because you may not be a candidate for physical therapy anymore. We found something dangerous. So I will always do that, because we have you do things in here that a physician would never do. And that's where sometimes all the other symptoms may come up that the physician may not see when you're in front of them, because they're not doing squats and stuff in front of you. So arthritis alone is not going to be able to explain that. And if you notice, there are times when you've got arthritis where you're telling me that you have zero pain some days. And then there are times when you got the same arthritis on the same MRI, and it's excruciating. You can barely make it out of bed those other days. So there's one thing that consistently remains the same, is that it may not be your anatomy as much, especially if that's not making much of an influence that's going on in there. So you can start expanding the biopsychosocial response, and you can start explaining other things that might be responsible for causing the pain to come up. So this is a collection over here of some of the best metaphors that I like to use from some of the most brainy, smart, brilliant people that put together. Having dinner, you can go out with pain, and you can date pain, tease it, touch it, nudge it, is what Adrian likes to mention in there. But don't marry it. Brushing your teeth, for the people who need to pace their activities. If they overdo stuff all the time, I like bringing up, hey, it's like brushing your teeth. You want to expose yourself to like 2 minutes, 3 minutes, maybe 2 times a day, 3 times a day. And you want to be able to do that instead of 2 hours for 1 day a week, overdoing it. And then you don't brush your teeth again for the next week for another 2 hours straight. So there's going to be a lot of bleeding gums, a lot of unhappy people who won't be able to eat at all when they're pushing themselves to that limit. The sunburn, I like that for nociception, towards my arm was hanging out of the door in my car. It got a sunburn. My nociceptors turned their volume up to become a little bit louder. And those are basically emergency signal sensors that detect if there's something dangerous in there. And chemically, it changes itself to become more sensitive, to where a 100-degree shower feels great on this side, but 100-degree shower on this side feels amplified and feels worse, because my brain is receiving signals that maybe there's 200 degrees worth of temperature that's hitting this spot. And when my brain feels like there's 200 degrees that's hitting it, it wants to cause pain to get us away from that. So this new skin can recover much better when it's not exposed to the same injury, that got them burned in the first place. So what is pain? According to IASP, definition is an unpleasant sensory emotional experience, with or resembling or that associated with actual or potential tissue damage. So actual damage, you kind of know what that is, right? Potential damage is if I was pulling my ear over here, and if I squeeze it, it's going to feel a little bit of pressure and not feel so good. If I yank on it like this, it feels even worse. And if I really yank on it, it starts becoming painful. Now, I let go of my ear. There was my pain right there, but I didn't necessarily do any damage to my ear just yet. I can imagine if I pulled harder, that potential damage would start becoming actual damage. So pain is there to protect you from your potential damage, if you haven't damaged anything yet, to become an actual injury. And getting rid of it is something that you don't want to do, because you have no protection from actually injuring yourself in the future. This one is the explanation for what is pain neuroscience education. It's a long one over here. It deals with peripheral sensitization, allodynia inhibition. And if you read it through, it's really long. I don't have time for that. And I know this stuff really well to where I can oversimplify it now. My simplest definition of pain neuroscience education is how we should theoretically answer our patients' questions and concerns about their pain using the facts, and not just one side of it. As over here, you'll see Prince William. There's a biopsychosocial, three things that encompass pain. And if you see just one of them, if you talk about the biomedical, if you talk about just the x-rays, if you talk about just hip positions, up slips, down slips, or just the cartilage or one meniscus, you'll get a different signal sign over here compared to a more accurate sign over here, where you get, hey, it's your sleep habits. Hey, it's your eating habits. Hey, it's your genetics that are involved. Your socioeconomic status. You're in a relationship where you're getting bullied. You're with friends that you need to distance yourself from. And that creates cortisol responses, that creates adrenal responses that go on. And that is responsible for also influencing how sensitive your nerves are and your nervous system and those nociceptors from sending emergency signals or sending much calmer signals in there. The anatomic studies over here have shown if you dissect the body, who's done anatomy and dissected the body and actually found a pain sensor? Because there's not one that's actually been found. There's no pain sensors in the body that can create pain. The only thing that we can accurately determine if somebody's in pain or not so far in their knee or their hip or their back is when we do fMRI scans of the brain, and it creates a neural sequence, this neurotag or this neural sequence. It links together 9 sections of the brain, and when we see that pattern come up, oh, there we go, now they're in pain. If I think of apple pie, the sequence becomes different. So parts of the brain end up communicating with each other to create, okay, I'm riding a bicycle now, or I'm thinking of apple pie. It's got its own neurotag that's in there. So sometimes I tell people, look at the front part over here. This might create brain fog if you have a prefrontal cortex issue and you can't access that because it's been hijacked by parts of the brain to create this pain meeting that's in there. These are the different influences that I like expanding into once it's been established that, hey, it's not just one thing, it's multiple things that are all responsible for creating pain. Sometimes it's cold outside. Sometimes you might have lost a job. Sometimes you might have lost a loved one. And that all creates cortisol responses. If somebody's yelling at me, somebody's bullying me, and you take my blood work, my cortisol levels are going to be through the roof. If you put me in a hammock in Hawaii with a Mai Tai in my hand and hula girls dancing in front of me, I'm not going to have that cortisol response if you take my blood work then. And I've had patients tell me that, hey, I was running on the beach in Hawaii. I was horseback. I even went boogie boarding. And I felt great that I came in here and all of a sudden my back pain is back again in here after walking out of my car through the parking lot, heading off to my desk at work at my school. So the context of the place also has an influence on that as well. So these are often also words that I like to use to where wear and tear can be used as wear and repair. And I like things that rhyme too because people remember it a little bit better. You know, your pelvis is out of place and then you want to add to that, but it's not dislocated in here. It might be out of place, but you can put it into places where you feel more comfortable, where you feel safer, where you feel stronger in there at. A blown out disc, and I usually finish their sentence, I got a blown out disc, but it can actually resorb to its original state after about 10 months in about 75% of the population to 100% of its original state. And there's new studies out there right now that I saw recently that show anywhere between 3 months to 6 months, there's disc resorption on these proliferated and extruded discs. The more horrific the disc problem is, it seems like the better the outcomes of the reversal later on. You know, so over here, how should we as clinicians explain pictures again? Right? We can start flipping it to expanding on the things that they can control, what's in their internal locus of control. They can control the environment they're in. They can control their eating habits. And we can start using words such as, you're strong, you're adaptable, you the man, you know? And according to Lowe over here, if you have MedBridge, he mentions about the positive environments versus the negative environments where you might experience pain. We need to be able to use our language to create a positive environment. So kids playing at a playground, they're having fun. They get hurt for some reason. It's not too painful. Rodeos, these cowboys, really tough. They fall off a horse and bounce back up. It's not quite as painful when they report those to us. Over here, if you get in a car accident, that's not your fault in particular. If you're in combat and you're fighting something and you don't even believe in the war that you're in, is meaningful to you. If you're at work and you're not getting along with your boss, those are negative environments, have shown that 8 times increase in pain based on that the placement of that. So sometimes I like having people, okay, where's your safe spot? Let's go there. So over here, these are posters that I have available that I use in the Spine Center, and you're welcome to use them too. They have a copy in La Mirada as well. Pain kind of works like an alarm system. This is the best metaphor that we've seen so far, that, hey, in my house, I've got this CPU. This sounds the alarm if the sensors in my door, if my radar is picking up movement, if my window sensors go off, somebody breaks that, it'll send a signal to this, but only this can set off the alarm. Just like my brain is the only thing that can set off my alarm, which is my pain signals that I feel. If I have sensors in my hands and they send off a signal, we've not seen so far that a sensor in the hands or a sensor in the foot can actually produce pain. It requires the CPU to receive that information, to process it, to make sure that it sounds threatening. Let's send a painful signal to warn us about that thing. A few years ago, I was running with my dog, and this is where context matters in the location we were talking about. Run through the curve, I twisted my ankle. Most of the time I ask people, and they think, hey, that would hurt your ankle, right? If you twisted it and you fell. And I was running with my dog, and I was laying in the street when that happened. Let's look at it from a different context. I'm still laying on the street, but now I hear this bus with the brakes screeching. He's the driver. I look up and he's honking his horn, and he can't stop, and he's heading toward me. Is my ankle still going to hurt as I'm laying on the street? So it may not, or it may hurt less, but now I'm concerned about the rest of me surviving, not just my ankle. My brain starts deciding, okay, let's save Ken, make his ankle maybe hopefully stop hurting. Let's get some adrenaline in there, which actually can block emergency signals from reaching my brain, and let's get my dog off the sidewalk, right? So now I'm safe. I'm on the sidewalk. Is my ankle still going to hurt? Maybe it'll, oh, that's right, we had this ankle thing we just twisted a few moments ago before this bus came around. Social environments can affect our pain as well. Let's say I'm running on a treadmill over here. I twist my ankle, but then I look up. It's like I see somebody attractive. Is my ankle going to hurt then, you think? So this was there was some work done by Dr. Tasha Stanton about seeing all kinds of small tears that she saw on an ankle, and it was the wrong X-ray. It wasn't her X-ray, or it wasn't her MRI, and she started feeling ankle pain, and they drew up her actual. And she's a researcher. She's like one of the top ones in Australia for this. So the most important thing for me, I think, is why is it important to teach pain? It's because our patients ask us all the time about it. I get nonstop questions about pain every day. Why does this hurt? I'm hurting again. Why is this happening? And I've not had good answers in the past, but now I feel like I do. So it's an important communication tool. Another thing is, because there's also strong recommendations to now include it in JOSPT. How effective is it? I like the faces over here. For every 2 patients we see, we improve 1 for function. For every 3 patients we see in pain, we improve 1 out of every 3. And this is the number needed to treat, by the way. To improve acute pain, for every 4 patients, we're effective with 1 of them. So don't get too bummed out about yourself. It's like, oh, I'm not helping 100% of my patients. I'm not even helping 80% of my patients. This is what the stats are. And you think, wow, that kind of sucks. I thought we were better than that. But check this out. For medication, the best medication is gabapentin for treating pain. And for chronic low back pain, it takes 6 patients to get gabapentin before 1 person will have a good response to that. SSRIs, serotonin uptake inhibitors. It takes 7 patients for them to give that medication to before 1 gets a good response and effect from it. Think about the side effects that they're getting. They don't get the side effects that PT does, where we could talk to patients and we can have them do exercise and create their own serotonin and keep it there. Epidural steroid injection, 11 patients to receive something like that in there. All right, so my takeaway is that you want to be able to take your patient this afternoon and just try for 2 minutes. Try for 2 minutes. Try some of the words that worked out in here. You can use a sheet, and I think that will work. Just start 1 word at a time, and it'll start becoming more fluent. Thank you very much. All right.